Good afternoon, and thank you for coming to the CTSI seminar series. And today it is a talk that is sponsored by the Metabolism theme. And my name is Ania Jastreboff, and I'm here to present to you the presenter that is going to present her. And the reason I asked to do that is because I want to give honor to the presenter as well, and this is Yijun Chen. He's a bariatric surgeon, and he's a bariatric surgeon that made a big impact on science in this campus because he put the effort and all the resources in order to collaborate with a variety of laboratories that are basic and translational. And right now he has a network of collaborations that are going on. Both with animal models and human. And we learned a lot thanks to the bariatric program here at UCLA, thanks to him. So thank you, Yijun, and please come.
Thanks, Oren. Hello, everybody. Today, we are very honored to have Dr. Ania Jastreboff from Yale to give the presentation titled Anti-Obesity Pharmacotherapy, The Future is Now. Ania is a nationally and internationally renowned clinician and researcher. Her research includes both large multi-center clinical trials using anti-obesity medications as well as recently. She served as a lead author on the SURMOUNT-1 clinical trial. The data of this paper was published last year in New England Journal of Medicine. I think most people in this room knows well about this paper. And it investigated novel GLP-1 receptor agonist tirzepatide for the treatment for obesity. For the people in the obesity treatment field, the days before 2010 were pretty disappointing. Bariatric surgery was very effective, but generally speaking, people don't like it to get cut. So it was very underutilized. And the diet exercise, generally speaking, will fail probably about 80 to 90% of the patients in the long term. And at that time, the medication, the efficacy was about 3–5%. Orlistat, phentermine. And a lot of people actually didn't want to take it for a long time. In 2012, we had Qsymia got approved, which was better, improved efficacy to about 10–12%. But still, very, very few people are using that medication for side effects, for cost, for all kinds of reasons. Basically, I think the medication Qsymia made minimal impact for the obesity treatment. The good news is that the last few years, first, semaglutide got approved, and that improved the efficacy to about 15% in non-diabetic patient population. That was great. I think a few weeks ago, a lot of people saw the Wall Street Journal paper talking about everybody in Hollywood is on Wegovy right now. Everybody lost 20 pounds because they're on this medication. And I think even better news is what Ania is going to talk about, the tirzepatide. First time in history, improved the efficacy above 20% is getting very close to the surgery level. It's very amazing for a medication. Ania graduated from Bucknell University with a bachelor degree in art history. She got her MD degree in University of Maryland at Baltimore, and she stayed on, did her residency there, got her fellowship at Yale and a PhD at Yale. She has a very long CV with so many publications, grant support, invited talks. I know that she works very hard every day to improve the anti-obesity medications and to make the bariatric surgeon like me disappear in the near future. Every time, when surgery is competing with medicine, surgery loses. Ania's research is supported by NIH, NIDDK, and industry-funded global multi-center clinical trials. Ania, welcome. One thing I need to say that we should have invited you on a different date. Let's say that in March or April when it's warmer. Today in Los Angeles is very cold. Okay, I want to tell you. I don't know how cold Yale is.
It's colder than here, colder than here. Thank you so much. Thank you for the wonderful introduction. And we all need to be working together. And that's really the goal of obesity treatment. So medications and surgery together, there's plenty of work to be done. Okay, so let's get started. If the clicker works. The clicker does not work. Okay, so we will try and click a different way. Maybe they can fix it. Oh, here he comes. If it does not work, I will just click on the thing. Oh, perfect. Okay, awesome. Here we are, first slide. These are my disclosures. They're all related to the exciting and emerging field of obesity medicine. So let me ask you a question. What if there was one thing that you could do to transform your patients' lives? One thing. And what if I told you that that one thing was treating your patient's obesity and treating it in such a way that not only did they lose weight, but they maintain that weight reduction? So for the next 40 minutes, I'd like to invite you to set aside any preconceived notions you may have about obesity, what it is, what causes it, and even how to treat it. And open your minds and be curious to treating obesity as you would treat any other chronic treatable disease. So let's start with a patient case. So this young patient came to see me when she was just 18 years old. Her BMI was 57. She already had pre-diabetes, obstructive sleep apnea. Both of her parents had diabetes, and she was very afraid of developing diabetes herself. She was considering bariatric surgery, and she wanted to see what other options she had before pursuing that. So what did we do? She was already taking metformin. We continued this and implemented some lifestyle change. We then added liraglutide, a GLP-1 receptor agonist. We then added bupropion naltrexone, and you can see she had a marked response to this medication. And this is over a period of 3 years. Then when semaglutide became available on the market, we switched out the liraglutide for semaglutide. And you can see that over this time course, she lost nearly 140 pounds with a total body weight reduction of 44%. BMI decreased to 31 and her A1C normalized. Now, what you can also see is that actually at this point now, she's lost over 150 pounds. So she does not have to be unique. And she isn't anymore. But how are we doing in terms of treating obesity? Are we doing this? Are we treating obesity? Well, let's take a look. So what I'm showing you here on this graph are the proportion of individuals who would qualify for treatment with anti-obesity medications in the United States. And as you can see here, it's about 46% of adults meeting criteria. Now let's see how many individuals are actually getting appropriate anti-obesity pharmacotherapy. And it's 2%. So for what disease is it okay to treat only 2% of individuals? Is it okay for diabetes? Is it okay for cancer? Is it okay for any disease? And of course, the answer is no. It's not okay to treat only 2% of people with obesity. And for bariatric surgery, it's even worse. It's less than 1%. Now, how are we doing in terms of other diseases? Well, here's type 2 diabetes just for a comparison. We're treating about 86%. So we're not perfect, but we're certainly better than the abysmal 2%. So why is this? So in order to answer this question, we're going to focus in on a patient, and we're going to come back to him throughout the course of my talk because he taught me so much about treating obesity. So by the time I saw him, his body mass index was 47, so he already had obesity. And he said, "Doc, I'm a walking time bomb. It's only a matter of time before I have a heart attack. Can you help me? I need to lose weight." He was also considering bariatric surgery, but was very anxious and did not want to pursue it at the time. Now, he, like many of our patients, gained weight over time. He started out with a BMI of 24 in his 20s, and then he gained weight until he reached this BMI of over 40 in his 50s. Now, he had tried multiple things, and they always worked. He always lost weight. Look, with meal replacement, he lost 60 pounds, but the common theme was that he always regained the weight. So it wasn't that he couldn't lose weight, it was that he couldn't maintain. He already had type 2 diabetes, hypertension, hyperlipidemia. He was taking a bunch of medications. His A1C was 8.5, so his diabetes was not well controlled. And so when I took a closer look at him, I said, okay, he's taking 2 medicines for his diabetes. He's taking 2 medicines for his high blood pressure. He's taking a statin. So when we care for this patient with obesity, why are the diseases of type 2 diabetes, hypertension, hyperlipidemia all being addressed, but not the disease of obesity, not the disease that is causing or contributing to all of these other diseases? Okay, so what medications do we have for treating obesity? Well, there's several medications that are FDA approved for obesity treatment, and you see them listed out here, and then setmelanotide for monogenic forms of obesity. So we have all these choices. Additionally, we have medications that are used for obesity treatment that are not specifically FDA approved for that indication. But as we all know, so many of the medications that we prescribe not necessarily for the indication. And the reason I highlight them here is, for example, topiramate, bupropion, and naltrexone, they're components of the anti-obesity medications that are FDA approved. So for our patients who do not have insurance coverage for obesity treatment, we can certainly use the generic components, and we do. That's what I did in the first patient that I showed you with bupropion and naltrexone. Additionally, for patients who have type 2 diabetes, they can get additional coverage for medications that can help with their weight as well. So, of course, GLP-1 receptor agonists that we're going to talk about today, tirzepatide, pramlintide, as well as SGLT2 inhibitors. So additional choices. So there are options, and yet we're not using them. The indication for using these medications is a BMI of greater than or equal to 30 or a BMI of greater than or equal to 27 with a weight-related condition such as type 2 diabetes, hypertension, or hyperlipidemia. Okay, so why aren't we using them? There's many challenges and barriers, and I'm going to list out a few here. The one that I'm going to focus on for a majority of my talk is that the perception that obesity is not a disease. Now, there's also the fear of causing dangerous side effects or harm. So anti-obesity medications have a sordid history with various harmful effects that happened with some of them. So there is this, worry that what if we do something that is dangerous? Now, when I get asked this question, for example, about semaglutide, I say, well, GLP-1 receptor agonists have been used for over a decade and a half for treating patients with type 2 diabetes. So we do have some longer term data. Same thing, naltrexone, bupropion, topiramate. These are medications that have been used for other indications for years. Now, the perception that anti-obesity medications are not effective, of course, that is changing rapidly in real time, and we're going to focus in on that. The challenge of cost. So obesity treatment is still not covered by so many insurance carriers, and the cost is the highest right now than it will ever be for these medications. And that will also change over time, and many of us are lobbying to help with that. And then the challenge of scalability. So by 2030, half of Americans are projected to have a BMI of greater than 30. So we need to figure out ways that we can scale this treatment. And we did not shy away from this with hypertension, with hyperlipidemia, with diabetes. And so we should not shy away from this in terms of obesity. Okay, so let's focus in on the perception that obesity is not a disease. So again, back to our patient. What is the common theme? Well, he tried all these different things: caloric reduction, meal replacement, Mediterranean diet, exercise. He always lost weight, but he always gained it back. He was hungry, he had cravings. And when he stopped his meal replacement, he gained the weight back. Okay, so that's the common theme. So then the question is, why is it so difficult to lose and maintain weight loss? It's not that we can't lose weight, it's the maintaining that's difficult. Well, of course, there's this very complex and beautiful system that evolved over thousands of years, where our body has created this system where hormones signal to the brain about our energy homeostatic state. And of course, our body has this concerted interest in carrying an appropriate amount of fuel or energy, and it does this by carrying fat. And so our body and brain wants to carry a certain amount of fat. It defends this. It does not want to carry too little fat because then we would starve. And it does not want to carry too much fat. Then we won't be able to do our activities of daily life. And so the brain defends this fat mass. Now let's superimpose on that an environment that developed or evolved much more quickly than this beautiful system, our obesogenic environment. So let's look at this a little bit more closely. So here you have a house, and the house has a thermostat, and that thermostat is set to, let's say, 70 degrees Fahrenheit. So what happens when it is hot outside? Not like in LA today, but maybe somewhere else. So the thermostat senses, okay, it's 80 degrees. Okay, so I'm going to turn the air conditioner on. This is not conscious. You don't walk over to the thermostat. It just does this. In the same way, when it is cold outside, the opposite happens and the furnace turns on. Now, what happens when it's very hot outside? Okay, let's say it's August in LA or July in LA. Well, it gets more and more difficult to change that, to maintain that set point. And sometimes it's not possible to do that. And you have to turn up the thermostat or the system will break. So it turns out, of course, our body does this with many things, right? We call this homeostasis, whether it's body temperature, red blood cell mass, electrolyte balance, and it does this with body fat mass. So the defended fat mass, and this is, again, this is a set point model. It basically, this is our brain. Our brain is the thermostat, and it defends this fat mass set point. So what happens is when we gain weight, or specifically when we gain fat mass, this signals to our brain via hormones what is occurring, that we have gained fat mass. And in response, what should happen is increased thermogenesis and decreased appetite. And the converse should happen when we lose weight, or specifically when we lose fat mass. Now let's superimpose on that the obesogenic environment. So the food, the stress, the lack of physical activity, the increase in all the different things that we do that aren't necessarily good. And so what happens is that defended fat mass set point gets pushed up on a population level. So someone who may have had, let's say, a defended fat mass that was lower 100 years ago, that has now been pushed up. So what is obesity? So obesity results from an inappropriate setting of that defended fat mass. And so that means that obesity treatment requires resetting of that fat mass, of that defended fat mass set point. And this is key, because the goal of obesity treatment is not weight loss. The goal of obesity treatment is resetting the defended fat mass. And as a consequence, we lose weight. And this is really key. Okay, so we're talking about anti-obesity medications. So what does this have to do with this? Well, the goal of treatment with anti-obesity medications is to decrease the defended fat mass set point. So here is your defended fat mass set point getting pushed up by all these different things in our obesogenic environment. And here are anti-obesity medications, hopefully decreasing that defended fat mass set point. Now, how do these medicines do this? Well, that's another $1 million question, right? We don't know how the body sets this defended fat mass, and how do these medications work? Well, again, we think that the brain is controlling this, and look at the anti-obesity medications. They work in the brain. Now, what you don't see on here is orlistat or SGLT2 inhibitors. They don't work in the brain, and we don't think that they reset the defended fat mass, which is why potentially people eat back what they lost via urine or stool. But these, they all work in the brain. So we're gonna, and setmelanotide as well. So what we're gonna focus on today is we're gonna talk a little bit about semaglutide and tirzepatide. And so when we think about this, we can think about the past and the future, and leaping forward into the future. Yes, hopefully not leaping into the ditch, but leaping forward into the future. Thank you, Richard. Both Richards over here. So leaping forward. And so what do I mean by this? Well, with these new anti-obesity medications, we are at a watershed moment, and it's brought on by the recent introduction of these highly effective anti-obesity medications. And obesity research, in my opinion, will dominate the next half century of medical investigation. So if any of you are trying to decide about your career right now, this is it. I'm biased, but this is it. Okay, so let's talk about this a little bit. Here we were puttering along We had some good medicines, as I showed you, but they weren't highly efficacious. Then setmelanotide, we're targeting mechanism, and then semaglutide. And we started to leap forward. And now we have all these anti-obesity medications in development. There are so many, phase 1, 2, and 3. And we're going to focus in a little bit on nutrient-stimulated hormone-based medications. So let's talk about this. Okay, so what are nutrient-stimulated hormones? Well, they're hormones, of course, that are secreted when we eat food. So all of you are eating lunch right now, you are secreting these hormones. GLP-1 is the one that has gotten the most focus. Now, of course, there's many others, and I've listed just 3 others here, but there are many more. So GIP, glucagon, and amylin. So what do these hormones do? Well, they signal to our brain our energy homeostatic state, and they impact food intake and potentially energy expenditure. Okay, great. So now we have GLP-1, but we can pair that with other nutrient-stimulated hormones to make dual agonists as well as triple agonists. So pairing them with GIP, amylin, glucagon. So semaglutide. So semaglutide 2.4 is FDA approved for obesity treatment, chronic weight management. It's also FDA approved at a slightly lower dose for type 2 diabetes. And this was the first one that really demonstrated this higher efficacy. It's a once weekly injectable medication. And the placebo-subtracted difference in the trial was 12.4. And if you look at the on-treatment effect, it was actually 16.9. So nearly 17% body weight loss with this medication. Additionally, a third of participants in the STEP 1 trial lost over 20% of their total body weight. So really highly efficacious and first time of that an effect of that magnitude. Now, where is semaglutide 2.4 right now? Well, just published a couple of months ago is the STEP 5 trial, which looked at semaglutide 2.4 over the course of 2 years. And what we can see, as I showed you before, was a 16.9% total body weight reduction, and that is maintained over the second year of the study. Additionally, just FDA approved is semaglutide 2.4 for adolescents age 12 and above. And here in the STEP Teens trial, the percent change in BMI was 16.1%. So also highly efficacious and now FDA approved for adolescents as well. Okay, so let's talk about tirzepatide. So tirzepatide is different. It is a single molecule. It's a GIP GLP-1 receptor agonist. And this is the SURMOUNT-1 trial that was mentioned in the introduction. So in this trial, we included over 2,000 participants, average BMI of 38. More than 40% of them had prediabetes. And we looked at 3 different doses of tirzepatide, 5, 10, and 15 milligrams compared to placebo. And what we found was that on treatment with the highest dose, 15 milligrams, the average weight reduction was 22.5%, which had never been seen before. These are striking results. And the placebo-subtracted difference was 20.1%. And in the trial, the placebo-subtracted difference was 17.8%. So really, really striking results. But of course, our patients always ask us, well, 22.5%, what does that mean? How much weight am I actually going to lose? So the average weight reduction on this dose was 52 pounds. And there's great variability. We're going to come to that in a little bit. But that means that some people lost 10 or 15 pounds, whereas other people lost in excess of 100 pounds. So on this highest dose of 15 milligrams, additionally, nearly 40% of participants lost a quarter of their body weight. So that means if you started the trial and you weighed 200 pounds, at the end of the trial, you would have weighed 150 pounds. Additionally, more than 9 out of 10 participants lost weight. And this is also something different that hadn't been seen before, because of course, not everybody responds to every treatment because there are different types of obesity. And now what's next for tirzepatide? Now, the thing that I most get asked about is, well, when is it going to be FDA approved for obesity treatment? Tirzepatide is already FDA approved for type 2 diabetes. It was approved in June for type 2 diabetes. And I don't have a crystal ball, so I don't know, but this is what I do know. So in terms of the SURMOUNT-1 trial, it's continuing in terms of the diabetes prevention extension for those individuals who have prediabetes, who had prediabetes at the start of the trial. And then additionally, there are 3 more trials in the SURMOUNT program. SURMOUNT-2 looking at individuals with type 2 diabetes and obesity. SURMOUNT-3 looking at intensive lifestyle program and tirzepatide afterwards, and then a maintenance weight loss maintenance trial. Additionally, SURMOUNT-MMO just started at the end of last year, and this will include over 15,000 participants looking at both primary and secondary prevention. So it's not simply a cardiovascular outcomes trial, it's more than that. And just like with semaglutide that is looking at that in the SELECT trial, this is somewhat different, but a very, very interesting trial. Additionally, the FDA granted fast track designation for tirzepatide. So once SURMOUNT-2 is completed, then they will have all the information that they need to make their decision about the indication of obesity for tirzepatide. And if we have time, I can get into more about the trial if you're interested in knowing more about this medication. Another medication that is very interesting, and this one's on the horizon, is CagriSema. And this is a combination. So cagrilintide is an amylin analog, and it's being paired with semaglutide. So two molecules, not one molecule like tirzepatide, but two molecules paired together. So what do we know about CagriSema? Well, in this trial, what they did is they compared semaglutide 2.4, that's the green line right there. They compared it to combining semaglutide with cagrilintide. And you can see here that with these higher doses of cagrilintide and semaglutide 2.4, at just 20 weeks, participants achieved 17.1% total body weight reduction on average. And this is at 20 weeks. So just to put this into context, they have not plateaued yet. So you can see that they are still losing weight. And so we'll have to see where their plateau is when we go further out in terms of the timeline. Okay, so where are we going with CagriSema? So the REDEFINE trial, this is now phase 3, is looking at cagrilintide and semaglutide for obesity treatment, and then REDEFINE 2 is looking at cagrilintide for participants with obesity and type 2 diabetes. So these have just started. So I mentioned a couple of agents or 3 agents to you, but there are many others. So here's semaglutide, tirzepatide, and cagrilintide or CagriSema. And then I also mentioned to you that there are cardiovascular outcomes trials. So for tirzepatide, it's SURMOUNT-MMO, and for semaglutide, it's SELECT CVOT, and SELECT will read out this year. And this will be really, really important because so far, all of our cardiovascular outcomes trials have looked at individuals already with type 2 diabetes, looking at secondary cardiovascular events, whereas this one is looking at people with obesity without type 2 diabetes. So that will be a very, very interesting trial and will read out. Now, what about other agents? So there are also glucagon GLP-1 receptor agonists in development, and I've listed a couple for you here. And then there is also a GIP GLP-1 glucagon receptor agonist, so a triple receptor agonist, and it was just announced that it will be entering phase 3 this year. Now, additionally, all the medicines I've shown you are injectable, once weekly injectable, but there are also oral GLP-1 receptor agonists in development, and semaglutide in the OASIS program is the farthest along, anticipated to complete phase 3 relatively soon. So on this slide, it's literally, I'm not even showing you phase 1. This is just phase 2 and 3. And this is just the nutrient-stimulated hormone-based medications. And then finally, there's a monthly GIP receptor antagonist, GLP-1 receptor agonist that showed an average weight reduction of 14.5% at 12 weeks. So yet another one that is in development. Now, I focused on the nutrient-stimulated hormones. I'm just going to highlight that there are other medications and other mechanisms that we need to focus on. So for example, bimagrumab is a monoclonal antibody that blocks activin 2 receptor, and infusion every 4 weeks. So again, this is a monthly, resulted in loss in fat mass of more than 20% and gain in lean mass of 3.6%. So another mechanism and another one to look out for. So really what we're talking about is filling the treatment gap and beyond. So we've talked about this treatment gap forever between intensive lifestyle, the current pharmacotherapy that we had, endoscopic procedures, and then bariatric surgery and combination therapy. And now really these new therapies are filling that gap and beyond. So in terms of combination therapy with the different agents, the older agents and the newer ones, as well as combining them with bariatric surgery. So if we think about going beyond just weight reduction. Think about really going to treating obesity, treating the disease of obesity. So we need to target the neurometabolic pathophysiology of obesity. We need to target different mechanisms, and that's important because of heterogeneity of response. There are different types of obesity. They will respond differently to different treatments. We need to individualize combination therapy. So again, this allows for targeting of different mechanisms. So you can combine different medicines together or combine them with surgery or other procedures. We also need to consider the quality of weight reduction. So far, all we've been focusing on is how much weight are people going to lose. But really what we want is we want them to lose fat mass, not lean mass, or lose as little lean mass as they can. So again, potentially we can get to gain of lean mass while loss of fat mass. We also need to consider the rate of weight reduction. What is too fast, right? What is too fast and what is healthy? So we need to think about that. And because overall, our goal is to improve the health outcomes and the lives of all individuals living with obesity. And of course, access and affordability is key. This is something that we have to keep at the forefront at all times, because what good are all of these tools if our patients don't have access to them? Okay, so let's come back to our patient and kind of focus back in on him and what he has taught me and taught all of us about treating obesity. Okay, so back to him. Here he is with all of his medications and his weight-related diseases. So we're going to ask ourselves 3 questions. And we're going to ask ourselves these 3 questions for these other diseases. And then we're going to ask the parallel question for obesity. Okay, so the first question is, do we find it unusual that this patient requires several medications for his diabetes? Is that weird? No, it's something we would expect, right? He needs more than one medicine. Do we think that do we think the anti-hyperglycemic medications are not effective because his A1C is not less than 7? No, maybe he just needs another medicine, or maybe the medicines he's taking aren't the right medicines for him. And the third question is, now that his blood pressure is at goal, would we stop his antihypertensive medication? Would we ever do that? What happens if we stop it? His blood pressure is going to go back up. So we wouldn't do that. Okay, so here's our 3 questions, and the answer to all of these questions is no. So now let's talk about this in the context of obesity, and obesity as a disease that is heterogeneous, that is chronic, and that is complex. Okay, so first, heterogeneous. What's the question there? The question here is, do we think that the anti-hyperglycemic medications are not effective because his A1C is not less than 7? And the parallel question is, do we think that the anti-obesity medications are not effective if his BMI is not less than 25? Okay, so let's talk about that. So the average efficacy of these medications was mentioned before, and now we see it's going up, but it varies. So the same thing for anti-hyperglycemic medications is not the same for every patient, right? And so the only medicine that is treat to target is insulin. All the other ones have variability. There's variability in response to these medications, and most of the time, more than one medication is required to reach goal. So let's look at tirzepatide again. So what happened when in the trial in terms of looking at how much weight people lost? So what I'm going to show you here are waterfall plots. This is in the supplemental of the paper. So this is the distribution of % change in weight for each participant. So each participant is on this graph. And what you see here on the y-axis is the % body weight change. So here is our dashed gray line. So everything above this line is increase % body weight change, and everything below the line is decrease. And here you are looking at placebo. So the participants in the middle had no weight change. And so about 67% lost weight. And you can see that some of them lost very little weight, and some of them lost a lot of weight. And here are the patients who gained weight. And again, some patients gained a little bit of weight and some patients gained a lot of weight. So now let's look at this waterfall plot for tirzepatide. So here's tirzepatide 15 milligrams. The first thing that you see is the entire graph is completely shifted. And what you see here is that a majority of people, 97, almost 98%, lost weight, and about 2.3% gained weight. And again, what you can see is this great variability. Some people lost a little bit of weight, but most people lost a lot of weight. And so what this shows us is, well, first, nearly all individuals lost weight with 10 and 15 milligrams. Here I'm showing you 15 milligrams. And there's heterogeneity in response to tirzepatide, as with all therapies for obesity. So let's look at a couple of other therapies. So you can look at this for anything. You can look at this for any of the medications. You can look at this for bariatric surgery. People lose different amounts of weight. So how do we incorporate this into treatment? What do? Well, you can start a patient on one medicine, and then you can add another medicine, and then you can add another medicine. So if a patient loses 5% with one, 10% with another, altogether, they might lose 20%, or maybe there's synergy and they may lose more than that. They may lose 25%, or maybe they'll lose less. And of course, now with the highly effective agents that we have, they can potentially lose a lot more weight. And so the take home here is that obesity is a heterogeneous disease. There's wide variability in response to anti-obesity medications. And that's because there's not one type of obesity, just like there's not one type of diabetes. So there are many types of obesity. We're just not far enough along yet to understand the different types of obesity and to have biomarkers to be able to identify them. And maybe some of you can figure that out. Okay, the next thing is obesity is a complex disease. So here the question is, do we find it unusual that this patient requires several medications for his diabetes? And the parallel question for obesity is, do we find it unusual that he may require several medications for his obesity? Right? We've always been like, oh, there has to be one magic pill or one magic shot. Well, maybe there doesn't. Maybe people need more than one medicine. So here is an example of a patient with type 2 diabetes. So they come in and let's say their hemoglobin A1C is 9 or 10. So you start a medication, they begin to respond, and their hemoglobin A1C starts to come down, but it's not yet at goal. So what would you do? Their A1C is not at goal. Well, you would add a second medication, but maybe the patient doesn't respond, or maybe they have side effects to the second medication. So you stop the second medication and you add a third medication. And now their hemoglobin A1C continues to decrease, and now it is at goal. Great. So you tried 3 medications and you continue 2 of them. Now let's look at the patient with obesity. So they come in and they have an elevated defended fat mass. And you see that clinically, we measure it as BMI. So what do? We start a medication. What happens? Well, hopefully they respond. Their defended body fat mass at that point hopefully starts to go down and they start to lose weight. So they're not at goal, they plateau. So you add a second medication, but potentially they have side effects or they don't respond. So what do? You add a third medication. And now the patient continues to decrease their defended fat mass set point, and they continue to lose weight, and then they plateau. And then if they're at goal, you continue those 2 medications. If they're not at goal, you would add another medication, just like I did with the first patient that I showed you. Okay, so this speaks to the fact that obesity is complex and combination therapy is often needed, as it would be for any other complex disease. Okay, the final concept, obesity is chronic. So the question here is, now that his blood pressure is at goal, would we stop his antihypertensive medication? And the parallel question is, when his weight, BMI, or in my opinion, his defended fat mass set point is at goal, would we stop his anti-obesity medications? Okay, so let's look at a patient with hypertension. So you have a patient with hypertension and you start them on an antihypertensive medication. What happens? Well, hopefully their blood pressure improves. So great, you continue the medicine. They might need another one down the road, but they're doing great. So now what happens if the medication is stopped? Well, of course, their blood pressure goes back up. We're not surprised. You stop the treatment, right? Why would their blood pressure stay down? It wouldn't. So now let's look at the patient with obesity. They come in, they have an elevated defended fat mass. What do? You start a medication. What happens? The patient usually says, well, I lost the weight. Can I stop the medicine? And we have a discussion, right? Because if they stop the medicine, what's going to happen? Their defended fat mass is going to go back up and the weight is going to follow. So in order to maintain the weight reduction, in order to maintain the decreased defended fat mass, we have to continue the medication just as we would for any other chronic disease. Now, this is not a theory anymore. This has been shown in several trials now. And the most recent one is the STEP 1 trial extension. So this is the trial that looked at semaglutide 2.4. And what you can see here is medication was started, placebo is in gray, medication is in the blue squares, and participants lost weight. And this is at a year, 68 weeks, just over a year. So what happens when the medication was stopped? Well, the defended fat mass went up, and so weight was regained. We should not be surprised we stopped the treatment. So the take home here is that obesity is a chronic disease. There's no cure, and that necessitates lifelong treatment. Okay, so back to our patient and what happened with him. So this is, again, over the course of several years. Again, he came in with a BMI of 47 and his A1C was 8.5. We continued his treatment with metformin and lifestyle. We added liraglutide. Then his weight decreased, but his A1C was not yet at goal. So we added an SGLT2 inhibitor. His A1C improved and his weight plateaued, but you can see it was already decreasing to the lower 40s in terms of BMI. Then we increased his liraglutide. We titrated it slowly over time to a dose of 3 milligrams. Then we added naltrexone bupropion. Unfortunately, he developed a side effect. He developed constipation, and another provider recommended that he drink prune juice. Well, prune juice is very high in sugar. It did not resolve his constipation. It did result in an elevation in his A1C. He stopped the prune juice, he stopped the naltrexone bupropion, and we replaced his liraglutide with semaglutide, and he had a very nice response to this. So at this point, his weight reduction was 85 pounds. Total body weight reduction was 27%. His BMI decreased to 34 and his A1C is 6.4. He continued 3 of his original medications and was able to discontinue 3 others. And he is in a much healthier place. And again, this patient does not have to be unique. And this was before we had, we had semaglutide, but we didn't even have the higher doses of semaglutide or tirzepatide. So I'm going to end with a quote from a participant. And I think it's really because our patients and our participants really teach us everything. I think if we just listen to our patients and our participants, they will give us all the answers. And so this is a participant in the SURMOUNT-1 trial and at the Yale site, and she lost 92 pounds during the course of a year, truly transforming her life. And this is what she said to me. And I think it sums up the fact that this was targeting mechanism for her. And what she said was, it's just as easy to lose weight as it ever was to gain weight. And I think that really says it all. So thank you. I hope I've inspired you to treat obesity as you would treat any other disease, or if you were debating what course of action to take in terms of your research, that you will focus on obesity. And I would love to take your questions. And if you have further questions about the SURMOUNT-1 trial or anything else, I'm happy to answer those. Thank you. Yes.
So first of all, thank you so much.
You also have that.
Yeah. So thank you so much. It was absolutely great to hear your talk. My question is the following: we started the goal of new line therapies. We need to reset the defending muscle, right? We discussed the problem to push it back. And it could be linked in the way with preventing, by using this new line.
Oh, sorry. Oh, shall I start from the beginning? So, okay. Yeah. Okay. So I was really impressed, and I really like the rationale that the new line therapists have to have this new goal to reset the defended lipid mass, which makes to me a lot of sense. And that means that, for example, what you proposed further with new therapies, new line of therapies, that, they are controlling weight quite well. However, the question is first, which data support the idea that they have achieved that goal of resetting the defended lipid mass? Given the fact that they are still symptomatological, so they are not curative, and from what you have implied, it seems that their durability is such, I mean, durability in the treatment is such that proposes continuous therapy rather than short-term therapy. So that's my question.
Yeah. So again, coming back to the idea of hypertension, you have to continue the treatment in order to maintain that lower blood pressure. So in the same way, why would we think that we would just make the defended fat mass something else? We don't want that defended fat mass to be fixed. And here's why. So let's say that you're a woman and you decide to have a baby. Your defended fat mass has to go up to support the development of that baby. Let's say that you're a teenager and you're going through puberty. Your fat mass is going to change. So this set point, it's just a name. It's not a great name. It's not really a set point. It's something that's mutable that can change over time. And it always has, and it still does. We still change up and down within our lifetime, depending on what's happening with physiology. If you have bariatric surgery, it goes down. If you take these medications, it goes down. But again, you have to continue the treatment in order to maintain that. Just like with hypertension, just like with diabetes. If you take a medicine to improve the hyperglycemia, if you take it away, that hyperglycemia is going to come back to wherever it was before. And it's the same way with this. But we don't want it to be fixed, at least not yet. Maybe there will be a way to cure obesity where you can still have a mutable defended fat mass, but in a lower place.
So what is perceived there? Is it coming there?
Yes.
If they're regaining weight, which means that makes the effect is similar to what was in the past.
So it's, and again, just like if you were to stop a medicine for hypertension, your hypertension would come back. It would come back. So yes, the trial that I showed, the step 1 extension, that demonstrated that. So again, the goal is not weight loss. I mean, you could say re-regulation of physiology, but in some way our body's actually responding appropriately to our environment. That's how our body responded to it. So it's just that our environment is such where that defended fat mass is elevated. Now, to the point of, this is a model. We have no idea how the fat mass is set. No idea. All of you in this room must figure this out, please. Because on a molecular level, we have no idea. And if we figure that out, maybe we can have other treatments. Same thing for hypertension. If you can figure out what there's different etiologies for hypertension, then maybe we can give someone one thing one time and their hypertension is cured forever. We don't have that for many chronic diseases, and we don't have that for obesity either. Yeah, thank you for your question. Yes.
Hi, thank you so much for your talk. So you see a variability in response with the different trials and the different anti-obesity drug treatments. How correlated are these responses to patient demographics, such as like race, genetic, environmental factors? And do you see one that stands out versus the other, or certain population that responds better?
Yeah, so there's a lot of research looking at that and trying to find biomarkers, genetic, indications, et cetera, to specifically parse that out and phenotype different types of obesity. We do know, for example, that for GLP-1s, someone who has type 2 diabetes is on average going to lose less weight than someone who does not have type 2 diabetes. And so we know that there's a difference there. Maybe it's the beta cell. I don't know. Maybe you can figure that out. Anyway, my point is that, so we do know there are some differences based on that. There hasn't been a signal yet in terms of, some of the other factors that you mentioned, but I'm sure that down the road, we will parse that out. And again, we have to figure out what are the different types of obesity. The only reason why we call it obesity is because the common factor is excess adiposity, right? So just like for diabetes, we're like, okay, well, it's hyperglycemia. But type 1 diabetes is not type 2 diabetes, right? So there's, monogenic forms. So anyway, there's different types of obesity.
Yeah, following on your answer, when we look at the data very carefully, it's very interesting that for both semaglutide and tirzepatide, the weight loss of diabetic population is much, much less. As I remember.
Yes, yeah.
Yeah. Semaglutide is 10% versus 15%.
Yeah, it's about a 5% difference.
Yeah, tirzepatide even bigger is 10% versus 22%.
Yeah.
we have seen a little bit in bariatric, patients, bariatric patients with diabetes,
Mhm.
they tend to lose a little bit less weight
Than people without.
without.
Yeah.
But this difference is bigger than what we have seen in bariatric surgery.
Yeah.
Do you know how to explain that?
Yeah, no, we don't. And this is, again, this is where some of the research really needs to be done because we don't know. We don't know. Yeah. Research topic.
That's
Collaboration.
cool.
I know, that's cool. Yeah.
exactly the
Yeah.
kind of discussions we have to have.
Yeah.
Because we, the basic research scientists, we tend to research things that were relevant 20 years ago.
This is relevant
It's a
today.
tradition.
This-
I think, to me, that was one of the first meetings that the metabolism team had, was that when Yi-Jun actually stepped on the stage and said, here's the questions the way I see it, the clinicians, and we said, oh, wow, we didn't know that those are the questions.
Yeah.
So this is very interesting. I also agree with you that obesity research is going to surge right now. And I already see it in terms of funding opportunities for obesity,
Mhm.
thanks to these specific drugs.
Yeah.
And thanks to the fact that insurance companies are starting to open their pockets towards obesity treatment. There is funding more for obesity research right now than there was before.
Mhm.
And so I have a question in terms of the population that you're saying when you stop the treatment, there is a regain of weight. But is there any group or subpopulation that are showing less of regain of weight that we can learn from them? What are the parameters that are inducing this regain and those that are preventing this regain? Are there studies that are looking at, for example, if we are exceeding the reduction of weight, not just to go to BMI of 25,
Yeah.
but to go to BMI of 23 or 22, will a specific amount of time on that will prevent the regain?
Yeah.
Would do the complete reset?
Yeah, we don't know yet. And those are some of the really key questions that are exactly being asked. And even if you look at, for example, interventions that are not medications, there are certain people who respond more, who don't have cravings, don't have hunger, and they do well. With bariatric surgery, again, there are people who lose a tremendous amount of weight, and there are the rare individuals who don't. But we don't know in terms of like resetting of defended fat mass and what may play into, okay, you're not going to gain back all the weight. Maybe you'll gain back less of the weight. So we don't know yet, but those are exactly the types of questions that I think a lot of us are asking and looking at. Great question.
Is there any data on lifespan?
With these medicines, no, not yet.
What do you think?
And with bariatric surgery, there's also already data in terms of cancer outcome that was published in JAMA last year. But again, I think we need more time to look at that. But I would imagine, if I had to speculate, it would help with lifespan, but yeah.
Yeah, with bariatric surgery,
Yeah.
we have very good data on lifespan, especially in obese and diabetic population.
Mhm.
For example, if there's a patient who is 45 years old with BMI 45 with type 2 diabetes, if this patient had a bariatric surgery, this patient is going to live about 6.7 years longer. If the patient is younger, if the patient is 30 years old with a BMI of 35 with type 2 diabetes, this patient is going to live about 12 years longer. I do think that with that degree of weight loss, we're going to see a pretty significant increase of lifespan.
Thank you so much for sharing this beautiful presentation. I just had a question about one of the specific therapies, and that was CagriSema.
Mhm.
I noticed that at 25 weeks, there was an increase in the weight gain. Is that just lifestyle related, or that can happen with some of the medication, and how would you address that?
The medication was stopped. So thank you for raising that. And I should have said that. So basically, my point there was that patients hadn't plateaued yet. The medicine was stopped. So exactly what we see in the other trials is that the weight is regained. And so the question there is, of course, and the trials are ongoing now in phase 3, is to see where patients will land given that by 20 weeks, they had already lost 17.1% of their total body weight. Yeah.
Thank you
Great.
so much.
Yeah, absolutely. Great question.
So I was wondering about the weight loss. Is it primarily driven by a rise in food intake or effects on energy expenditure?
So there's a decrease in food intake, and I have a whole nother talk about these medicines and how to prescribe and, you know, how to mitigate side effects. There's great way to mitigate side effects, and that's slow up titration of the medicine. And that is, you know, by far the strongest thing we can do, but also some things our patients can do. In terms of food intake, it acutely goes down. So what happens is, again, the idea being that you start taking a medicine and that if you respond, it decreases your defended fat mass. Then what happens is that your body is trying to get to that defended fat mass. It's trying to lose weight to get to that new set point. And so during that weight reduction phase, food intake is dramatically decreased. It's like people who have bariatric surgery, they eat significantly less. And then when a person reaches plateau, what we're seeing clinically is that there are days where they eat more and there are days where they eat less. On average, they're still eating less, but there are days they eat more and there are days they eat less. They have a little bit more flexibility. But during the weight reduction phase, people tend to not be hungry, they don't crave, they're kind of like done. Like they'll eat a third of what's on their plate and they're like, they feel like they just ate Thanksgiving dinner and they're just done. They don't want seconds, they don't want to eat the rest of it. Once they get to plateau, hunger and craving can come back. And so oftentimes our patients get anxious. Oh my gosh, I'm going to gain back the weight, but they don't. Again, some days they eat a little bit more, some days they eat less. And it's like they're regulating to that new defended fat mass set point. And as this participant said, it's just as easy to lose weight as it ever was to gain weight.
Yeah.
And a second question, sorry, Orion. So
Can I expand on the question? Just, then you do the follow-up question?
that's fine.
So because he was asking like energy.
Oh, energy expenditure, yeah.
So, and you know, I'm very interested in what was happening to the interest of those patients to do physical activity, because that's one of the things I think that is changing. Obesity is inhibiting the interest to do physical activity.
So in SURMOUNT, I don't know in terms of physical activity, that wasn't a specific questionnaire that we asked. We are asking physical activity questions in an R1 that I have with semaglutide, so we may have that answer specifically for you in a couple of years. In terms of energy expenditure, there's animal data looking at these agents, and you know, we'll have to see in terms of humans how these are affecting that. But in my opinion, it's not just the intake. Yeah.
Great. So the other question I had, what about populations that we know have a higher risk of obesity, right? You look at parents, you know, parents are obese. And if you look at, you know, the offspring, they essentially will probably follow a similar path in their body weight. What about using some of these drugs to prevent the weight gain?
Yeah, that's a great question.
At-risk population.
Yeah, that's a great question. And certainly something that's come up in many discussions. We're not quite there yet, but I think if we have a crystal ball and look forward into the future, yeah. Well, I mean, we'll just have to see. We're serious right now. We are definitely not there yet. Yeah, but there are 4 FDA approved anti-obesity. You know, some of the ones that are FDA approved for adults that are now FDA approved for 12 and above, for age 12 and above. So, yeah.
All right, I
Great
think now
question.
it's 1 o'clock.
Oh,
Thanks very much again.
absolutely.
Wonderful talk.
My pleasure.